My name is Pervez Sultan, and I'm the senior and corresponding author for the expert review entitled Epidural-related maternal fever, incidence, pathophysiology, outcomes and management. None of the authors have any relevant financial disclosures. Epidural-related maternal fever is a clinical phenomenon which was first described by Fusey et al. In 1989. It affects approximately 15 to 25% of patients who receive a labour epidural, with an adjusted odds ratios between 3 to 14.5 when confounding factors are accounted for. There have been two published meta-analyses which demonstrate that epidural-related maternal fever is a true clinical phenomenon, which is unlikely to be a result of selection bias. All commonly used neuraxial techniques, including epidural and combined spinal epidural, and local anaesthetics, including bupivacaine and ropivacaine, with or without the use of opioids, and different maintenance regimens, for example, continuous infusions and intermittent epidural bolus techniques, all appear to be associated with the development of epidural-related maternal fever. Two major theories surrounding epidural-related maternal fever development have been proposed. Firstly, a sterile inflammatory process, and secondly, thermoregulatory mechanisms. And we're going to go into a little bit more detail in the next two slides about these theories. So firstly, labour epidural analgesia may lead to the development of hypothermia through a sterile, non-infectious inflammatory process. This process may involve reduced activation of caspase-1, which is a protease involved in cell apoptosis and activation of pro-inflammatory pathways, secondary to bupivacaine, which impairs the release of the anti-pyrogenic cytokine interleukin-1 receptor antagonist, which is also abbreviated to IL-1RA from circulating leukocytes. Detailed mechanistic processes of epidural-related maternal fever still remain to be fully determined. These processes are summarised in the diagram in this slide. Secondly, thermoregulatory mechanisms involving impaired sweating, increased shivering and reduced vasoconstriction secondary to neuraxial blockade have also been proposed, which may contribute to the development of epidural-related maternal fever. Sweating is a physiological mechanism used by the body normally to dissipate heat. Inhibition of sweating therefore reduces heat loss and increases body temperature. Vasoconstriction due to decreased body temperature or baroreceptor reflexes and non-thermoregulatory vasoconstriction may also contribute to heat retention and therefore epidural-related maternal fever. Inhibition of vasodilatation can also result in heat retention. Labour is painful and pain is associated with hyperventilation. Excellent pain relief often provided by labour epidural analgesia can therefore result in relative hypoventilation compared to women who have inferior non-epidural analgesia. Hyperventilation or an increased respiratory rate results in heat dissipation, therefore hypoventilation or a reduction in respiratory rate is associated with labour epidural analgesia, which can contribute to heat retention in this way. Finally, decreased shivering threshold may result in greater shivering, which creates heat and increases body temperature, which may also predispose patients with labour epidural analgesia to the development of fever. These concepts are summarised in this figure. Epidural-related maternal fever is associated with worse outcomes for both the mother and the neonate. Epidural-related maternal fever is associated with more fever workups and consultations, including investigations such as complete blood count, blood cultures and other cultures, and increased antibiotic administration in the mother. Intrapartum fever may also be associated with abnormal labour curves or fetal intolerance to labour which are both associated with increased need for operative vaginal delivery. Intrapartum fever of any etiology, including epidural-related maternal fever, is associated with neonatal morbidity, including hypotonia, early onset seizures in the baby, reduced APGAR scores, increased requirements for ventilation, and increased neonatal sepsis evaluations, neonatal antibiotic administration, and neonatal intensive care admissions. Currently, there is no prophylactic strategy which can safely prevent epidural-related maternal fever from occurring, nor can it easily be clinically distinguished from other causes of intrapartum fever, such as chorioamnionitis. Since intrapartum fever of any etiology is associated with adverse outcomes for both mother and baby, it is important that all parturients who develop intrapartum fever are investigated and treated appropriately, irrespective of labour epidural utilisation. Institution of treatment with appropriate antimicrobial therapy is recommended if an infectious cause of fever is suspected. There is currently insufficient evidence to warrant a change in recommendations regarding provision of labour epidural analgesia, and the benefits of good quality labour analgesia must continue to be reiterated to expectant mothers. So in summary, epidural-related maternal fever is a clinical phenomenon which affects approximately 15 to 25% of parturients receiving a labour epidural. The etiology is not fully understood. However, it is likely to be multifactorial, with sterile inflammation and alterations of thermoregulatory mechanisms considered to be the most likely potential mechanisms for this phenomenon. Currently, there is no treatment strategy which can safely prevent epidural-related maternal fever from occurring, nor can it easily be clinically distinguished from other causes of intrapartum fever. Since intrapartum fever of any etiology is associated with adverse outcomes for both mother and baby, it is important that all parturients who develop intrapartum fever are investigated and treated appropriately, irrespective of whether the patient receives a labour epidural. There is currently insufficient evidence to warrant a change in recommendations regarding provision of labour epidural analgesia, and the benefits of good quality labour analgesia must be reiterated and highlighted to expectant mothers. And ultimately, effective pain management during labour and delivery is associated with favourable psychological pain and quality of postpartum recovery related outcomes, which are of paramount importance when planning labour and delivery. Thank you.